Okay, my talk today is on catheter-related bloodstream infections. Dr. Tatum was my mentor for this. Here's a brief outline, going through definition of catheter-related bloodstream infection. It's slightly different from catheter-associated bloodstream infection. We'll go through that. Some more about epidemiology, microbiology, all the way down, and towards the end, we went through some meta-analysis and some research studies. So bloodstream infections in the hospital, the important cause of morbidity and mortality. For the last decade, maybe even beyond, we have an estimated 250,000 cases each year in this country. Then the estimated mortality for each infection is extremely high, 12 to 25%. Not to mention the cost, it's about $25,000 per episode. Now, if you go only into the ICUs, there's about 80,000 of those 250,000 cases that occur in the ICUs in our country each year. Most of them are primary. You can see it's about 2/3, and they're associated with intravascular catheters, and in particular central venous catheters. You can have second infections that are usually seated elsewhere, like the urinary tract, lung, post-op wounds, and skin. Yeah. So this is the definition of catheter-related bloodstream infection. So here, the organism that is identified in peripheral blood is also present in significant quantities at the tip of the catheter, or when you have a blood sample drawn through the catheter. I'll show you what significant quantities means in a few slides. This is what we use in clinical practice, and again, it requires evidence of the catheter involvement. It has to have the same organism as that in the peripheral blood. This is slightly different from catheter-associated bloodstream infections. I won't go into that definition. Just know that that's mainly used for epidemiological surveys and, like by CDC's healthcare safety network. Risk factors among the host: patients with chronic illness, immune deficiency, especially neutropenia, extremes of age, young and very old, those who have had previous bloodstream infections in the hospital, loss of skin integrity, patients who are malnourished, those who are on TPN, which we find rarely now, and bone marrow transplant. When you go to catheters, these are all more common sense material. It's duration of catheterization, the type of material used, condition of insertion, catheter site care, and the actual skill of the inserter. I'll go a little more into these. So when you look at peripheral intravascular catheters, there's more chance of infection left extremity versus or an upper extremity. A lower extremity versus an upper extremity. More in the wrist versus the hand. Infection increases when placement is more than 3 or 4 days, and with Teflon it's lower. It's higher with PVC or polyethylene catheters. With arterial, colonization at site and placement more than 4 to 6 days. Now these two also factor in for the PA catheters along with the rest of them. Shield sleeves are naturally better than the plastic ones. When we use submaximal barrier precautions, and subclavian is probably better than the IJ, though we do the IJ site now. A few more terms of central venous catheter. Repeated catheterizations that carries a risk factor if there's a presence of septic focus elsewhere, and if it's non-tunneled versus tunneled, and the safest, as you can see, is implantable device. There is lower risk with antibiotic impregnated catheters. And lastly, catheter care factors. Whenever it's put in an emergency setting versus an elective, the skill of the inserter, someone who's more specialized, has a lower risk. Skin under the dressing, if it's moist, that has a high risk. Cutaneous antiseptics like 70% alcohol and 10% iodine carry more risk. And when you actually use the antibiotic lock solutions, I'll talk about this again later, there's lower risk in neutropenic patients when you use this. This is the incidence. In 2010, it's read as infections per 1,000 catheter days. And if you can see in the medical ICUs, this is across ICUs in major teaching hospitals in the country. you see the incidence actually 1.8. That's not bad at all. That's a very good rate, and I'll go through why it has come down in the next few slides. If you, as you can see, in burn it's more because that's a risk factor on its own for BSIs, but the rest of the ICUs are almost around the same. So 4 major sources of infection. Colonization is number 1, colonization from the skin. Interluminal or hub contamination when they're seeding from a bloodstream infection, or rarely contamination of the actual infusate. This picture should better explain it. So naturally, contamination of the skin, that's the major one. With endogenous flora, or we have extrinsic sources like healthcare worker, and contamination of the hub. If there is hematogenous seeding from another source, contamination of the device prior to insertion, that's rare. And the rarest is the last one you can see, the contaminated infusate. That's the rarest source. Microbiology. So before 1980s, gram-negative aerobes were predominant. Since then, gram-positive aerobes and Canada have increased in relevance. And the next slide is actually prospective analysis over 7 years. Among about 24,000 bloodstream infections in about 50 hospitals over those 7 years, and these organisms were brought up. So number 1 today is coagulous negative staph and Staphylococcus aureus. As you can see, they comprise 50% of all infections. Most of them are actually methicillin resistant now, and the rest of the bacteria, Enterococcus, Candida, E. coli mainly, and come down. So it's always good to wash your hands. This one?
Catheters are just nosocomial bloodstream infection.
Oh, nosocomial. No, this is Mongol. This was. So, are you saying the data might be different from catheter-related?
I was just curious if those numbers are all bloodstream infections nosocomial, like the title says, or is it catheter, either associated or related?
I can check on that and let you know. Clinical manifestations. Yeah, so you start developing a suspicion when bloodstream infection occurs in setting of a CVC place where there's no other source. Fever is the most sensitive manifestation, though it has poor specificity. Inflammation or purulence at the site has greater specificity but poor sensitivity. We can find other things like hemodynamic instability, alternative status in the patient, catheter dysfunction like an intraluminal clot, and signs of sepsis that start right after a catheter infusion. You can also see complications like suppurative thrombophlebitis, endocarditis, and metastatic infection. I'll run through two of those complications in the next slides. So, if you remember, these are the 4 major sources. And if you see number 4, that's how a thrombus can form at the edge of a catheter tip and leading to suppurative thrombophlebitis. So thrombus formation is common, and these can trap microbes, and proliferation of these can actually transform the thrombus into an intravascular abscess. That's what is known as suppurative thrombophlebitis. The most common organism being staph. You can have clinical manifestations like purulent drainage, limb swelling. Many times we see this, and actually septic emboli. Diagnosis requires actual evidence of thrombosis. Usually we do that by an ultrasound, and persistent septicemia where there is no other apparent source. Treatment naturally includes removal of the catheter and antibiotics for 4 to 6 weeks. Surgical exclusion is only reserved for rare cases of refractory septicemia. When it comes to endocarditis, so typical manifestation like a cardiac murmur can actually be absent in most of the patients when it involves staph. So endocarditis should be considered in all cases of staph aureus bacteremia, including those who appear to respond to antibiotics. Naturally, the diagnostic procedure of choice is TE, and we can find, we can have these findings: vegetations, new onset regurgitation, or perivalvular abscess. Antibiotic microbial therapy for 4 to 6 weeks is standard. Unfortunately, it has a high mortality rate. So diagnosis, when you go through blood cultures, like in the definition I said, the same organism in the blood should grow from the catheter tip or a blood sample drawn from the catheter. Alternatively, if you take 2 blood samples, they meet criteria for these two: quantitative blood cultures or differential time to positivity. I'll tell you what that is in the next slide. This is among blood cultures, and for catheter cultures, they should be performed when you suspect it is a source. So you culture the catheter. There's actually no role for routine catheter cultures when there is absence of clinical suspicion, and you culture the 5 centimeter tip rather than the subcutaneous segment. So this is the actual diagnosis in one good slide. So the first one is actually of the catheter tip. We call that a semi-quantitative culture. So the same organism on the tip and in the peripheral blood, where the growth on the tip is greater than 15 colony forming units in 24 hours. And these two are for blood cultures. In the differential quantitative, the same organism should be seen in the peripheral blood and catheter blood, and the colony count from the catheter is more than 3 times than the blood from the peripheral blood. I have a slide next which kind of shows that. And lastly, the differential time to positive culture is the same organism, and the onset of growth in the catheter blood is at least 2 hours before the onset in the peripheral blood. So this should explain it. So you see, this is what the definition is. It's present in significant quantities more than peripheral blood, at least by a ratio of 3:1. So when you have a diagnosis of acute fever and in a patient suspect of having a bloodstream infection, so those who are mild or moderately ill, actually go along this line. You start blood cultures and consider microbial therapy. If you don't have a fever, remove it. You can either do a Guidewire exchange or insert it to a new site, send off cultures. The sicker ones are on that side when they are seriously ill with hypertension and end organ damage. So you draw blood cultures, like how we said, remove the catheter, and initiate antimicrobial therapy. And if you see all the way down for staph aureus, it's for 5 to 7 days. So monitor closely for signs of infection, repeat blood cultures, and kind of go along that route. There's one slide to take away from today. This would be it. This is a center line bottle. I'll tell you why this is so important. This pretty much explains what you have to do. Hand hygiene. You use an alcohol-based hand rub or soap and water before and after. You manipulate with catheters. Barrier precautions. I'm sure we all seen this in practices in the ICU. And actually, it's maximal barrier precautions. Use the cap, mask, sterile gloves, the whole thing. Skin antisepsis. We all use this chlorhexidine-based solution. Many times I've seen, you've fully gone there and just put it in, and then you immediately do the procedure. Actually, you're supposed to allow 2 minutes to air dry. And naturally, cannulation site, you'd rather try the internal jugular over the femoral vein and remove the catheter when no longer needed. And this is why the incidence has declined to almost 60% over the last decade. That's a big drop by just following these. So cover yourself so well that might actually be scary. Antibiotic therapy. So generally, as soon as the cultures are drawn, you start empiric therapy before the actual culture and sensitivity data are available back to you. So initial choice depends on patient severity of illness, the risk factors like we spoke about, and the likely pathogens with the particular device that is intravascular. So generally, coag-negative staph are the most common. As we saw, it was more than 30%. Most are resistant to methicillin. In healthcare settings, we should start vancomycin. In institutions with high rate of MIC with vanc, we should use daptomycin. And linezolid is not an appropriate empiric therapy antibiotic. It's probably because it doesn't do well when we actually have bacteremia. So vancomycin has to be started. So duration of treatment, again, it's determined by the offending pathogen, the status of catheter, whether you decide to retain it or actually replace it, and the clinical response you get out of the patient. So those who show this 72 hours, that's the catch here. So those patients who show a favorable response in the first 72 hours, then we go by the offending organism. Coag-negative staph, again, the most common. When they're involved, if catheter is removed, continue it for 5 to 7 days, and if it's left in place for 10 to 14. Next slide is with Staph aureus. You can limit it to about 14 days if catheter is removed and the following. Patient is not diabetic or immunosuppressed. There's no intravascular prosthetic devices in place and no evidence of endocarditis. If any of these conditions are present, you go with 4 to 6 weeks of antibiotic therapy for staph. For enterococci or gram-negative bacilli, go with 7 to 14 days, irrespective of the catheter being replaced or retained. And for uncomplicated candida, it should be continued for 14 days after the first negative blood culture. So you keep, I've seen check blood cultures every 48 hours, and after the first negative, you continue for 14 days beyond that. This is antibiotic lock therapy. So it's recommended for all catheters which have to be left in place while the systemic antibiotics are going on. What this is it's the same antibiotic used systemically in a concentration of 2 to 5 milligram per ml in heparinized saline. What they do is you inject it into each lumen of the catheter and leave it there for 24 hours. And every 24 hours you replace it as long as the systemic antibiotic therapy is going on. So catheter is, has to be used in the lock therapy is not possible, then the actual systemic antibiotic should be delivered through the suspect lumen. So that's about antibiotics. So with the catheter itself, these are times that they have to be removed. Signs of severe sepsis, hemodynamic instability, evidence of metastatic infection. Already spoke about suppurative thrombophlebitis. That's the thrombus that forms at the end of a catheter tip. There is, again, 72 hours. The persistent bacteremia after 72 hours of antimicrobial therapy to which the organism is actually susceptible. So if there's persistent bacteremia, the catheter has to be removed. And lastly, difficult to treat organisms like Staph aureus, Pseudomonas, fungi, and mycobacteria. We can try salvage in some conditions. Again, once the organs before you just have to remove. It's kind of difficult when you have organisms of relatively low virulence. I guess that'll be a case-by-case basis. These are the organisms. If it's attempted, both systemic and antimicrobial lock therapy may be administered through the colonized catheter for the entire duration of therapy. So 2 sets of blood culture should be obtained after 72 hours. Again, the 72-hour thing is important. And if they're still positive, you have to remove the catheter. When do we pursue salvage? I mean, when patient is undergoing dialysis, pulmonary hypertension treatment. So this is when we can try salvage, but not when those organisms are present. When can we do a Guidewire exchange? So when the removal is necessary, but risk for complications of bleeding, reinsertion is high. It's acceptable, but problem is there are not a lot of studies describing successful Guidewire exchange. So this is approach to management. This is for short-term catheters. Short-term catheters are your peripheral IV catheters, central venous catheters, arterial catheters, PA catheters. The next one is on long-term catheters. That's more your Permacath, Portacath, and Hickman. So this is on short-term. So naturally, when they complicated, we spoke about all these complications. Suppurative Thrombophlebitis, Endocarditis, or osteo. You actually remove the catheter and you have to treat it for 4 to 6 weeks. Unless they have osteo, we go for 6 to 8. The uncomplicated side, again, fever resolves within 72 hours. So the 72 hours, that's number we have to keep aware. So if fever resolves within 72 hours, then there is no intravascular hardware. Then it all depends on the organisms. Once again, coag-negative staph and staph aureus, they account for 50% of all infections. And just remove the catheter, treat for 5 to 7 days. If they retain, you can go for a full 14 days. With Candida, remember again, it is 14 days beyond the last negative, the first negative blood culture. Again, this is for long-term catheters. Like I said, it's all the deep tunneled ports. Portacath, Permacath, and Hickman. Same thing, they're complicated. Remove it and treat for 7 to 10 days. If they actually find the same complications, you go for 4 to 6 weeks. Unless it's osteomyelitis, you go all the way to 8 weeks. And if it's uncomplicated, it just depends on the organisms. And this one is for patients who are undergoing dialysis with tunnel catheters. Naturally, draw antibiotics, draw blood cultures, and if they're negative, you stop the antibiotics. If there's a resolution of bacteremia in 2 to 3 days, then you go by the organism. You can try a Guidewire exchange if absolutely needed. But if they have persistent bacteremia or fungemia, you have to take the catheter out and give antibiotics for 4 to 6 weeks. So so when I researched this, we just put in catheter-related bloodstream infections. There are like 1,700 articles which come out. So I really try to focus on the meta-analysis, which will have a group of studies, or the most recent ones. This actually came out only in October. This is one of the latest ones. This is a study out of Spain where they compared 64 patients with this chlorhexidine-silver sulfadiazine, so CHSS, impregnated catheters, and they compared that to patients who had a standard catheter, and they were able to actually show that even at the femoral, when they went through the femoral venous axis, the bloodstream infection was low, colonization was low, and actually saved costs. So this is the table. Just focus on the standard catheter. Yeah, that's the number that they used, 190 of standard catheters, and the CHS impregnated catheters, they use 64. And if you come all the way down, if you see the duration of catheter use, they were about the same, 8.5 days plus or minus 4 days there. The other one was 9 plus or minus 5 days. In the standard catheter range, number of bloodstream infections were 14 out of the 190, and the chlorhexidine one, they were 0. Even if you go by bloodstream infection per 1,000 catheter days, it was 8.5 versus 0. And the cost was actually in euros. The maintenance for those. Naturally, you see it's much less. It's about 2.9 euros versus 18.22 here. So this, we also already saw this.
Were the people reporting whether it was infected or not blind to the type of catheter, and or was the primary team blind to the type of catheter? Those two.
Like the type of catheter that they used.
Yeah.
Yeah, they didn't mention that in the.
They didn't mention they were blind, you know? Because it's, you know, even if they don't do it on purpose, they're going to want to see an effect. So maybe they say, oh, well, that bacteria probably wasn't the line, that was probably the pneumonia, so I'll give them a 0. Right.
So we already saw this outcome.
Maybe it's nice to report all bacteria once we take care of it. That's the question, right? Whether it's related or not.
Yeah. Did they do that?
Not from what I saw. No. So yeah, we already saw that there. And the next one actually, they saw that they had longer bloodstream infection free time among the CHSS impregnated catheters compared to the standard ones. So this was over entire duration of 30 days. So that's 100% infection free time. So catheter without developing that bloodstream infection, that was 100%. So as you can see, the dotted line is for the CHSS catheters all through 30 days. Whereas the standard ones, they did start getting infected with time. By 20 days, there were 2 standard catheters left, and they both seemed to be infected. These 2 are both in femoral catheters. The same group did a similar one back in March for internal jugular venous catheters. Again, they used 391 standard and 245 CHSS, and if you see, the duration was about the same, and even then they were able to demonstrate the bloodstream infections in standard. It was 8:0, and even the cost was lower. And even back then they showed that you see a much higher number, 245 CHSS catheters. All of 50 days, they remained bloodstream infection free. What's that? This funny. So I'll go through 2 or 3 meta-analysis now. So there's another chlorhexidine-impregnated dressing study. So we went through 9 random control trials. They met the inclusion criteria. So what we saw was the use of chlorhexidine-impregnated dressing reduced prevalence of the bloodstream infection and also the catheter colonization. So these are studies from 98. Again, it's meta-analysis, so they studied a bunch of group of studies. So from 1998 all the way to 2012, this was the relative risk of bloodstream infection with the chlorhexidine-impregnated dressing. As you can see through that graph, it actually favors chlorhexidine versus the comparator. Next slide is for colonization with the same meta-analysis. Again, favors chlorhexidine even for risk of colonization. It's much lower with chlorhexidine. Yeah, this is in a little more detail. Like actually shows how many catheters were used and for how long. So the mean duration was about 7 to 10 days, maybe 20. The 4th one actually used long-term catheters, so that's why you see the 71.5 and 62.5. These were the long-term catheters, your deep tunneled Portman, Portocat, Hickman catheters. And naturally, compared to the control, CHE dressing catheters did pretty well. So that was the outcome of that meta-analysis. It's actually benefit in preventing colonization and the bloodstream infections. So this was another study. This is only for arterial catheters. Again, a meta-analysis. So 49 studies met criteria. Pooled incidence was 3.4 per 1,000 catheters, or 0.96 per 1,000 catheter days. They actually saw that prevalence was considerably higher when they cultured all catheters versus only when the arterial catheters were suspected as the source of bloodstream infection. They also found that there was a increased risk with the femoral site of insertion compared to a radial artery site. This explains in the graph. It's again all the way from 1983, a lot of studies through 2012. This is the plot of radial versus femoral catheter with regard to infection. You can see, the femorals have more risk. And this was the outcome they came up with. That arterial catheters are still an unrecognized cause, because we usually think about central venous catheters, and selection of a radial site will actually help reduce the risk of a bloodstream infection. So I have a couple more analysis. So this was even bigger one. This compared bloodstream infection in femoral catheters compared to subclavian and internal jugular. So 2 randomized controlled studies and 8 cohort studies met criteria. So all those catheters are placed. About 3,000 subclavian, 10,000 in IJ, and another 3,000 femoral vein, for a total of 113,000 catheter days. So the average CR BSI density was 2.5 per 1,000 days. This actually found that there was no significant difference between bloodstream infections in femoral and subclavian/IJ sites. IJ site was showed us significantly lower risk for bloodstream infection compared to femoral, and this also showed that depending on the year of publication, the older studies, the femoral site had a higher risk, and then they've leveled off in 2008 and 2012. If you can see, the earliest study was 1998, and as you can see, those 3 sites, subclavian, jugular, and femoral, especially the first one, the CR BSI per 1,000 days in the subclavian is 2.6, internal jugular was 1.4, and femoral was actually 6.3. So this was about 14 years back or 16 years back. Even in the next one, subclavian was 0.88 and femoral was about 3% there. But as we come down towards 2010, especially Harrison, you can see that they're all about the same. Subclavian, internal jugular, and femoral. Probably because of all the aseptic methods that we use now, much more stringent than 10-15 years ago. Again, this plot shows that subclavian is favored, and so does this. Subclavian and IJ favored over femoral. So the final outcome was that though the previous studies from 98 showed a low risk in internal jugular compared to femoral site, now they seem to have leveled off. They also assessed risk for DVT, and they actually found no risk, difference in risk of DVT even between these 3 sites. One last one. So this was a study came out yeah, just a few months ago. So this was a university hospital in Spain, a 900-bed hospital, and they observed uh, their house officers actually doing these lines. Um, so there, about 2,000 short-term catheters were used in about 1,500 patients for 8,000 catheter days, and then 280 long-term catheters were used. So they showed that the annual incidence density was 5.98 bloodstream infections per 1,000 for short-term and 0.57 bloodstream infections per 1,000 catheter days for long-term catheters. So about 114 insertion procedures were actually observed. Average insertion time was 13 minutes, and they made sure that compliance with these were followed. Same hand hygiene, chlorhexidine solution, mask, gloves, gown, cap, and complete aseptic technique. So this is a graph. As you can see, about 2,000 short-term catheters and 280 long-term catheters. By short-term, again, I meant your standard central venous catheters, Swan Gans. By long, again, I mentioned it was Hickman, Portacath, and Permacath. And these are the settings that they were placed in. Subclavian, jugular, femoral vein, and which hospital setting, ICU, OR. And yeah, this is what they found, the annual incidence density. Short-term catheters were about 5.98 and long-term was 0.57. Again, they broke it up into semesters there. And the incidence rate was 0.81 and 0.67. So the outcome of this study was that the bloodstream infection control and prevention program that was implemented, they actually were able to decrease the rate of catheter-related bloodstream infections and provided valuable information about total burden of the disease and ways to improve their interventions in the future. This is amongst our own hospital. This is all ICUs. This is 24. So this is between January 2010 all the way to July 2014. Again, all ICUs, not just MICUs. So you can see there's a so the 75th percentile is green, the 90th percentile is blue, and we had a uptick in few of those months. The red is the these are number of infections per 1,000 line days. There's an uptick in September 2011. So all ICUs, this is for MICU pods 1 to 5 in the same direction, Jan 2010 to July 2014. And if you want to go by each unit, this is pod 1 through 4, pod 1 and pod 2, pod 3 and pod 4, and that's pod 5. So all of those end in July 2014. For August of 2014, which is a couple of months back, there was only one CRBSI in MICU pod 2, in no other MICU. So all MICU was just one. They had one in P4 and one in Neuro ICU. So that all of August of 2014 they had 3. I called Nisreen Murad. She's part of the infectious control committee, and asked why this happened, and was there a certain trend? Was it a start date in July for new interns and all that? She said that was more with maintenance of the catheters. So catheters were placed for less than 5 days. It usually went on the person who placed the catheter. It was 5 days and beyond, like day 6, day 7, day 8. If they got an infection, it was usually on maintenance, which means how many times the catheters were used, pressing was not applied right. But they meet once a month for this. They go through what best ways to solve it. But she pretty much mentioned what I have as a summary. These are the sources of infection, 3 being the highest. That's colonization of the skin, 2 is the catheter hub, 4 is you know, steaming from another side. 1 is the least. It's from the actual infusate, and she pretty much said this. We've been following this every time an infection comes up here. We look at the this center line bundle, see if anything went wrong, or we can do things right. And like I said, if there's one slide you can take from this talk, it's this: hand hygiene, maximum barrier precautions. It's not just barrier; it's maximal barrier precautions. Remember to put on the chlorhexidine and leave it 2 minutes to air dry, and try for the IJ more than femoral, and remove it when you not need it. So Kedem was my mentor for this. Any questions? Thank you.